Hi, I'm Dr. Andrea Zaenglein, a pediatric dermatologist at the Penn State Hershey Medical Center and past president of the American Acne Rosacea Society. This webinar is all about emergency contraception and what every dermatologist needs to know about it. So first, I'm going to give you a little background to frame the issue. As you all know, isotretinoin is a teratogen. If a patient gets pregnant on it, it is very likely that that baby will have severe birth defects. It is also mostly prescribed to adolescents and young adults who may or may not be adequately protected against pregnancy. According to the most recent iPledge data released from the FDA meeting in March 2023, about half of patients choose abstinence as their form of birth control, and about a third choose combined oral contraceptives with male latex condom as their backup. Only about 14% of patients choose highly effective, long-acting forms of contraception, like the Nexplanon or IUD. Not surprisingly, failure to adhere to abstinence and failure to use that secondary form of birth control are the most common reasons for pregnancy on isotretinoin. And there are consistently about 180 to 190 pregnancies per year on isotretinoin, showing that our iPledge program, as it's currently implemented, has maxed out its effectiveness. Of patients who become pregnant, the majority have chosen to end the pregnancy with elective abortion, but depending on where you live, it may not be an option for your patient. This makes preventing pregnancy and emergency contraception all the more important. Another fact to recognize is that counseling about emergency contraception is actually required by the iPledge program. Whenever a patient signs their consent form, they sign off that they were counseled on how to use emergency contraception. Although clearly we are not doing this regularly. Also, and most importantly, in my opinion, if we do not counsel our patients on how to obtain and to use emergency contraception while we are prescribing them a known teratogen, we are failing to provide them the necessary information to prevent pregnancy, the goal of the iPledge program. None of us wants our patients to be faced with those tough choices. So, to help answer all of our questions on emergency contraception, I am joined by my colleague, Dr. Sarah Horvath, an associate professor of obstetrics and gynecology and an advanced planning specialist here at Penn State.
Thank you so much for having me. I'm really looking forward to the conversation.
All right, so I'm going to ask you all the questions that a dermatologist would want to know about emergency contraception. So first off, can you define what emergency contraception is for us?
Absolutely. Emergency contraception, also known as EC, is used postcoitally after either unprotected or underprotected sexual intercourse. EC acts to prevent pregnancy. And it does this by reducing the risk of pregnancy at any single act of intercourse. It has not been proven to reduce pregnancy rates at the population level, but we do know that depending on the method and timing used, you can reduce your risk of getting pregnant with any single act of intercourse by about half.
Okay, and the question that we get a lot from people that like my age that hadn't, emergency contraception was not taught to us in medical school or when this iPledge program even started. Can you clarify that emergency contraception is not an abortion?
Absolutely. So emergency contraception is completely different from the abortion pills. So they're not the same medications. We'll talk in depth about what emergency contraception really is, but those are commonly called Plan B, which is levonorgestrel, or Ella, which is ulipristal acetate. The abortion pills are actually mifepristone and misoprostol. The really important distinction is that the mechanism of action for the abortion medications is to act directly on the decidua and creating decidual necrosis, and then acting on the uterus to expel the pregnancy. The mechanism of action for emergency contraception is completely different, and it really acts by making sure that the ovulation doesn't occur. If ovulation doesn't occur, then the egg can't meet the sperm and no pregnancy can occur.
All right, so we always think of emergency contraception mostly as Plan B, but what are the other options that we have for emergency contraception for our patients?
Sure. So let me talk a little bit about Plan B first, just for maybe the folks in the room who haven't had a lot of experience with it. So Plan B is the brand name, but there are lots of them now because it's generic for levonorgestrel, 150 milligrams once. This is what we use now. For those of us that have been doing this for a long time, you might remember when we used to have the 75 milligrams that you would give twice instead, and they were 12 hours apart. And it turns out that it's just as effective and certainly easier for patients if you just do the double dose once. So that's what we do. So that's how all of the brands are now. It's technically labeled for up to 72 hours of use, which is 3 days, but it can actually be used up to 5 days, technically off label, but with more limited efficacy. So as with any form of emergency contraception, the sooner after the active intercourse you take it, the more effective it is. Like I said before, it acts before the luteinizing hormones surge in order to inhibit or delay ovulation until the sperm is no longer viable within the reproductive tract. Plan B is available over the counter or with a prescription, either one. And the reason that it's important to remember that it's that to give those prescriptions is that it is fully covered by insurance under the ACA if you have a prescription. If somebody's paying for it over the counter, it could be $40, $50, even $60. And as we know, for a lot of our younger patients in particular, that can be a really big burden.
Yeah, I can just imagine. I have 14-year-old patients that are on abstinence, 14, 15. If they fail abstinence and have sexual intercourse, how are they going to get the $50 and a ride to the CVS to pick up their emergency contraception? So I think that was one of the things that you taught me first, that is make sure to prescribe it. Like, why aren't you prescribing it? Especially because it's covered by the majority of insurances, and especially our Medicaid insurance. So that was always a great tip you taught me.
Absolutely. And there are more barriers than just cost, right? Although it's supposed to be available over the counter to patients without any age restrictions. Again, as you may remember, if you've been doing this for a little while, when the FDA first approved the levonorgestrel emergency contraception, there were age limits on it. And so, old habits die hard. And we have these secret shopper studies that show us that in many places, instead of these medications being truly over the counter, they're sometimes behind the counter. Sometimes they're in a lockbox. Sometimes they'll still ask for age restrictions, or they won't sell it to boys or men, even though none of those restrictions are supposed to be in place.
Yeah, we started a quality improvement project here at Penn State where we prescribe emergency contraception for all our patients that choose abstinence. So, and making sure that we're counseling patients accordingly. So you highlighted Plan B. What about Ella?
Great. So Ella is also an oral form of emergency contraception. Its generic name is ulipristal acetate, but there are no generics at this point. There's only the one brand on the market. It is labeled for use up to 5 days, so you're not off label if you're using it in that 4th or 5th day. It is more effective the sooner it's taken, just like the levonorgestrel, but it's actually more effective at all time points and at all BMIs than the levonorgestrel is. It's especially more effective at those higher BMIs, which is really important, although both of them do lose efficacy as BMI increases. A meta-analysis of comparative efficacy trials found a lower pregnancy rate among people who did use ulipristal acetate, so a 1.4% pregnancy rate for them compared to the levonorgestrel pregnancy rate of 2.2%. Just for folks to think about, somebody who didn't take emergency contraception, your average daily risk of pregnancy from one active intercourse is about 5.5%. Clearly that matters where you are in your cycle and all of those things. But again, if you're thinking about just averages in any day. And the difference is, the reason that you have better efficacy with your ulipristal acetate is that it can continue to work during that luteinizing hormone surge in order to inhibit or delay ovulation, whereas the levonorgestrel really has to be taken before that LH surge. And so that's really kind of the big difference and why the efficacy is a little bit better with the ulipristal acetate than it is with the levonorgestrel. One of the things that's really important to remember, though, is that ulipristal acetate can interact with progestins. What that means is two things that are really important for our patients. The first one is that if you're on any other form of hormonal contraception, you have to delay taking it for 5 days after you take ulipristal acetate in order not to have the efficacy of either of them be diminished. The other is that you can't take both forms of emergency contraception at the same time. They will actually counteract each other's efficacy. So you want to make sure that your patients understand less is more in this case. More is not more. Please do not take both. You will actually be counterproductive.
So if we're going back to our recommendation to prescribe emergency contraception for our patients, is there any advantage to prescribing Plan B over Ella then, since Ella covers more of the population given the weight the restrictions?
That's a great question. So a couple of things. One of the important things about Ella is that it's only available with a prescription. So you really want to be doing it, providing it advanced. And the reason is that, again, from secret shopper studies, we know that a very small minority of pharmacies actually carry the ulipristal acetate, like on the order of maybe 10 to at best 25% of pharmacies, depending on your geography. And so that advanced provision is super important because it gives the pharmacy time to order it, get it in stock, call your patient back, and then, they can use it more efficiently because, hey, I've got this, it's in my, it's in my medicine cabinet, it's in my purse, it's in my bedside table, wherever it is that they need to keep it so that they can take it as soon as possible. I think the reasons that you might do levonorgestrel instead of ulipristal acetate, there are a couple. One of them is that, again, it's just easier to find. So again, if you have somebody who you think might use it more than once, it's really nice for them to be able to have quick access. So I will sometimes give refills for people too. So I say, hey, if you use this, go get the refill, put that one in your bedside table. So I think that's part of it. I think the other part is, again, if you have patients who are maybe struggling with taking their medications according to plan, maybe having multiple medications, and they're already on oral contraceptive pills, saying to them, oh, hey, now you want to delay taking that oral contraceptive pill for 5 days after you take your Ella, but don't forget to restart it. That can get really complicated for some people. And so if you think that they're going to really struggle with those kinds of instructions, giving them the levonorgestrel can be better because they can take that and it's compatible with their OCPs.
All right. So, well, we dermatologists are mostly going to focus on the forms of emergency contraception that we're able to provide our patients and counsel on our patients. As this podcast is going out to, or webinar is going to be going out to adult providers as well. I'm mostly a pediatric provider. What can you tell us about other forms of emergency contraception that may be appropriate for certain patients that we will need to refer to our OBGYN colleagues?
Absolutely. So the other option would be to give someone an IUD instead of using the oral EC or in addition to. So the great advantage of having an intrauterine device or IUD placed for emergency contraception is that the copper IUD, which is the one that has been traditionally used, is actually more effective than either of the oral formulations. It has shown to be effective up to the full 5 days. And there are no weight requirements. So that one definitely doesn't change with BMI, which is wonderful. The downside is that you have to be able to find someone who is willing to give you an IUD within the shortest time frame possible from having unprotected intercourse, which we all know in our systems of healthcare is a very difficult thing to do. So For a dermatologist, your role, in that would be to sort of think about, do I have specialist OBGYNs in my area that I know, hey, I can call up and say, can you squeeze this person in tomorrow? Do I have complex family planning specialists who maybe already hold a spot on their calendar for these folks, and those sorts of things. The other thing that I think is really important for recognizing is that traditionally we only use the copper IUD for this, and a lot of folks, for whatever reason, they may not choose to use a copper IUD. They may prefer to have a levonorgestrel IUD. But there's actually a recent study by Dave Turok's group out of Utah that showed that the levonorgestrel IUD was actually non-inferior to the copper IUD as emergency contraception. And so good news that if your patient wants an ongoing levonorgestrel IUD, they can use that too.
Okay. I guess hopefully everybody has a friend like you that you can speed dial and call up in these cases of emergency contraception concerns. So are there any other last thoughts that you have that you would like to share with dermatologists about emergency contraception?
I think, this is a really safe medication to use. Again, emphasizing in this crazy world of stigma that this is not an abortifacient. This acts before implantation, before you have an established pregnancy, that this is completely different. So I think that's a really important thing. For those of us that have more pediatric patients, right, or things like that, reassuring folks that that the, advanced provision of emergency contraception does not lead to more sexual behaviors or more risky sexual behaviors, right? That we have study after study that shows that this is just there for the folks that are going to need it anyway. It doesn't encourage folks to need it if they haven't. And again, with that advanced provision, super important, because the sooner you can take this, the less stigma associated with it, the faster, the better. It's also really safe to take it more than once, although not recommended to be used as sort of the only form of contraception. So if you have a patient that you find is needing it more than once, it's important to, either have that conversation about ongoing contraception or send them on over to us, your friends in OBGYN, so we can have that ongoing conversation with them.
Yeah, I think that's the biggest concern that I think parents have is that being on like a form of birth control or having access to emergency contraception is going to increase the chances of the child or young person engaging in sexual activity, which we have good data to show that that is not the case. So that's one of the concerns that dermatologists have, and why only 50% of dermatologists actually prescribe combined oral contraceptives, even though they're approved for acne, is mostly concerns for these types of things. So it's great to have you here to reinforce that those are actually myths related to contraception. I want to thank you again for working with me on this project, and I'd like to thank Dr. Sarah Gold, who was the AARS fellow who worked on this as well. And for you guys out there that want to learn more about emergency contraception, and I refer you to our article that we just published in JAMA Dermatology, the viewpoint from April. It's entitled Emergency Contraception for Patients Taking Isotretinoin. There's a great table in there that you can download and use in your offices. It gives you all the information that Dr. Horvath just reviewed with us, and in an easy, clear format for you. Thank you.